This is Jerry Hesch from the Hesch Institute in Aurora, Colorado. And my client, John, is a 38-year-old male, very active, very fit. And he had a football injury to the left hip and has a long history of low back pain, hip pain, some episodic right knee pain, and also upper back and neck pain. He had a hip scope surgery in 2017.
It was on the right.
On the right hip. And you'll notice his internal rotation on the left hip is really good. I can rotate that leg into about 45 degrees. And on the right leg, I can bring him a little bit past neutral, and there's a firm end feel. So I'm not able to even spring it. Very, very tight. That's less than 10 degrees of internal rotation. So 45 on the left, 10 degrees on the right. He also has an interesting pattern in his pelvis. I will add that he's had about 20 sessions of Rolfing. And how many physical therapy visits?
30 to 40.
30 to 40.
Yeah.
Okay, and how many chiropractic visits?
30 to 40 also.
30 to 40 also.
Yeah.
Okay.
In the last 3 years.
In the last 3 years. Okay, alrighty. His pelvis, in standing and when he lays on his back, is asymmetrical. And the ASIS, this little bump on the front of the pelvis, is lower on the right. It's also anterior towards the ceiling, okay? And if I look at the space of the outer pelvis to the inside of that ASIS and compare sides, it's rather subtle, but I would say that this is medial. But more important than how it looks is how does it function. The pelvis should have mobility in all directions. And I'm testing posterior rotation, and there's good mobility. You can see the pelvis move with that spring. And when I do the same test on this side, I'm pushing with more force, and there's no movement at all. Do you feel the difference?
Oh, yeah.
Okay. Let's have you lie on your stomach. Let me check my camera angle. So when I come to the top of the pelvis, I can get some forward motion on each side, pushing on the ilium. Okay? And then when I push inferiorly towards his foot, we have good spring mobility on the left side, but we have no movement here. I cannot get movement to traverse through the right side. Okay? Interestingly, when I go superiorly, I can push and take up the slack, and then I can get some spring mobility. I see his head bobbing up and down. And on this side, I can take up the slack, and actually I see movement there as well. It gets interesting when we look at his lower pelvis. And I'm going to change the camera angle. And this is, I'm going to align his crease on his clothing to the crease of his body. So his midline gluteal crease is right here. My thumb is inside the sit bone on his right, and I'm about a thumb width and a half away from the midline. And on this side, I'm 2.5, if not 3 thumb widths away. So the lower pelvis looks swept over to the left. Now, maybe it developed that way, but I don't think so. The reason I don't think so is because when I try to induce passive spring mobility, this should move, and I'm putting a moderate amount of force and it doesn't move at all. And the same thing is true when I push on the right, on the inside of the sit bone. And then when I try and push medially, there's just, once I take up the slack, there is just no movement there and no movement this way. Okay, this is a pattern I stumbled on. It's not in the literature. It's in my book, but it's called a left lower windswept pelvis, not to be confused with the orthopedic pattern, which involves a fracture. The other thing I note is that the sacrotuberous ligament is from the bottom of the ILA of the sacrum and goes to the sit bone. So it's found by running your thumb this way, and you have to indent the glutes, and there it is right there. And I'm trying to indent that ligament. It doesn't move. It feels like bone. Okay? On the right sacrotuberous ligament, I can take up the slack and I can spring it. I can actually thrust it and it bounces. So this ligament being very tight further supports my belief that that pelvis is twisted to the left. I'm going to move my camera angle now. Okay, so the crease of your clothing matches the crease of your body. I'm on the inside of the sit bone on the right, and I'm on the inside of the sit bone on the left. And I think it's very obvious that this one is very close to the midline, and that this one is further lateral. Okay? Two other things that I find with him. This gives support to the fact that you need to test the body in multiple positions. When he sat up, he had blocked motion of his first thoracic vertebrae. I was not able to get spring motion through the spinous process. So does that mean that we need to manipulate that vertebrae? No. Because when he lays down and takes, gravity is no longer present and his body is no longer adapting to his lower body, that vertebrae has free mobility. What I do find is that the first rib that attaches to that vertebrae on the right side does not have mobility. So it's the first rib that needs to be freed up, and then that vertebrae should move normally. And this is second rib, and that springs. And this is first rib on the left, and that has good mobility. So his first rib is twisted in the transverse plane. And then the very last thing that I see is that his upper cervical spine is stuck in a hyperextended position at the second joint called the atlantoaxial, or C1, C2. Let's have you lie on your back, please. So when I test traction to his upper cervical spine, I have to do contact in front of the ear because the upper two joints are just below the ear and the rest of the cervical facet joints are in the back of the neck. So if I put my contact approximately on the temple, then I'm testing the upper joints. And when I take up the slack, then there's no movement after I take up the slack. Okay? If I bring you in slight flexion, I take up the slack, but then there's spring mobility. Okay? The other hint is that when I come under the mastoid process, there should be a depth called a sulcus, a deepening, and there's not much depth at all. I immediately hit the transverse process of C1, and I'm trying to spring C1 to the left, and I'm trying to spring it to the right, and there's just no movement there. Okay? But when I come under the mastoid, I can easily side bend you. I can easily rotate the mastoid in both directions, so it's not a problem of the occiput, where the occiput joins C1. It's a problem of the joint below that. And now I'm trying to rotate the atlas. There's very limited rotation on either side. Okay? And then if I were to put him in extension, and I'm just trying to keep your face out of the video. So now I'll drop the headpiece down. Okay. So now your head is in about 10 degrees of extension, and now we've lost all motion. I can't even take up the slack. I'm using a reasonable amount of force, and it feels like a block of granite. Okay? So we have much to do with you. I'm very curious to see if we can increase motion in your right hip. That might be developmental. I'm curious to see if we can increase motion in the pelvis. And I'm very confident we can increase motion in the first rib and in the upper cervical spine. And after we improve the motion, then I teach you how to keep it, and that's very, very easy, very straightforward. So I will stop filming now, and I will go to work. And we'll film the results, and I'll also demonstrate how I restored motion.